I have no financial interest or relationships to disclose, and I'd like to speak to you about Retinoblastoma 2021. First, I'd like to give credit to the numerous collaborators on the oncology service at Wills Eye Hospital who helped with the collection of many of these projects' data. It takes a village to manage one case of retinoblastoma, and we've been doing this for over 50 years at Wills Eye Hospital. For those of you very interested in this topic, we wrote a nice review article on modern treatment of retinoblastoma in the Indian Journal of Ophthalmology 2020. So we're going to talk about three topics: chemotherapy for retinoblastoma, unilateral sporadic retinoblastoma, and retinocytoma risks. For Retinoblastoma 2021, it's all about chemotherapy, various delivery methods. So let's talk about chemotherapy for retinoblastoma. The management of retinoblastoma still includes enucleation, especially if there's no hope for vision or the child looks like they have high-risk retinoblastoma, or if the parents are unreliable and chemotherapy is not available. Intravenous chemotherapy is used when there's bilateral retinoblastoma, and intraarterial chemotherapy when there's unilateral retinoblastoma. And then for vitreous and aqueous seeds, we use intravitreal or intracameral chemotherapy. Plaque radiotherapy is still our last-ditch method for the treatment of retinoblastoma if all above fails. So first, let's talk about intravenous chemotherapy. What about it? Well, I'll ask and answer 5 questions. Does intravenous chemotherapy work? Yes, it does. Do the results vary based on the International Classification of Retinoblastoma group? And the answer is yes. Is it lasting to 20 years and even longer? Yes. Do results vary based on patient's age? Surprisingly, yes. And what features predict recurrence? Well, I'll let you know. So if we look at intravenous chemotherapy, it's used to treat the eyes, of course, but it also treats the brain and helps prevent pinealoblastoma, and it can be used to prevent metastatic disease systemically. Here's a young child we saw several years ago with bilateral advanced retinoblastoma with total retinal detachment, both eyes. And following intravenous chemotherapy, the retina reattached in both eyes, and she's now over 20 years old with visual acuity of 20/30 in the right eye and 20/70 in the left eye. She has no metastatic disease. But is this lasting for all patients? Well, we published in British Journal of Ophthalmology 2020, long-term, 20-year, real-world outcomes of intravenous chemotherapy in 964 eyes of 554 patients at our center. And what we found in this large analysis, if you look at groups A, B, C, D, and E, intravenous chemotherapy is really successful for groups A, B, and C with over 93% of globes saved, 78% of group D, and 47% of group E. And this is at year 1 in blue. And look what happens at year 2. It's about the same. And at year 3, it's still about the same. And at year 5, the same, 10, the same, 20, the same. So basically what you have at year 2 or 3 is going to be lasting for 20 years or more. Now, how often with intravenous chemotherapy do we have to use additional intraarterial chemotherapy or plaque radiotherapy? So again, per group, A, B, C, D, E, we can see intraarterial chemotherapy is used in about 20% of cases, and plaque radiotherapy, again, in about 20% of cases. The IAC is used at a mean interval of 5 months and the plaque at 13 months, because we usually go to IAC before we go to plaque radiotherapy. So IAC overall, 17% of cases, and plaque radiation overall, about 19% of cases to save the eye. Now, what are the risk factors for tumor recurrence following primary intravenous chemotherapy? This was an analysis of 869 eyes. When does recurrence happen following intravenous chemotherapy? Well, we looked at this and we found at year 1, 2, and 3, we find most of our recurrences. It's very unusual to see recurrence after 3 years of age. So I tell our patients, if we can make it to 3 years of age with minimal or no recurrence, odds are we're not going to see recurrence, even up to 15 years of age. And the risks for recurrence include younger patient age, greater class on the International Classification of Retinoblastoma, closer proximity to the disc, and the presence of subretinal seeds, each with a minor impact on recurrence. So how about IAC, intraarterial chemotherapy? Well, we think it's best for exophytic retinoblastoma, especially if you can see an area where there's no tumor, because the tumor can shrink to a small scar and the retina usually reattaches. This is after 2 doses of intraarterial chemotherapy using melphalan. So we're coming out in the Journal of the American Academy of Pediatric Ophthalmology and Strabismus 2021, our review of our experience, intraarterial chemotherapy for retinoblastoma in 341 consecutive eyes, 1292 consecutive infusions. Here's an example of a boy who had group E retinoblastoma before A and B, and then after C and D, 5 cycles of intraarterial chemotherapy. The tumor beautifully regressed and the retina was flat. I have to be honest, he did require additional intravitreal chemotherapy. So if you look at this Kaplan-Meier plot, we look at 5 years follow-up. Group B has 100% globe salvage. Group C, 80%. Group D, 78%. And Group E, 55% globe salvage. Now, these are unilateral retinoblastomas that I'm highlighting here, and this is 5-year Kaplan-Meier results. So we do pretty good with Group B and C, and still pretty good with Group D. We're saving almost 80% of the eyes, and only 50% of the eyes with Group E. So overall, globe salvage was 76% by 5 years. Median 3 infusions, and complications once you get to be good at this procedure is only 1% per infusion. Now, what about intravitreal chemotherapy? Well, here you see before intravenous chemotherapy, then after intravenous chemotherapy, we still have vitreous seeds. So we give intravitreal chemotherapy and all the seeds clean up and we're left with a fovea, and this was the child's only remaining eye. So when we published on 192 consecutive injections, we found 100% tumor control. I don't think I've ever published a paper where we had 100% success, but this is the one paper where it was. And then we did a 10-center collaborative effort where we looked at risk for extraocular extension in eyes with retinoblastoma that get intravitreous chemotherapy, and we found no case of extraocular tumor extension. So Dr. Feroz Manjan-Davida and I published this nice article in the Indian Journal of Ophthalmology recently on the role of intravitreal chemotherapy for retinoblastoma. Now we use what's called precision intravitreal chemotherapy, where we actually give our injection right to the seeds directly using indirect ophthalmoscopy guidance. And we only do this when we have localized seeds. So for example, for this seed really close to the fovea, we deposit our chemotherapy with the indirect right there. We don't shake the eye. We position the head so that the chemotherapy stays there. And as you can see on follow-up, all tumor is gone and the fovea is looks actually in good health. Now, a few words about unilateral sporadic retinoblastoma. Previous publications have noted of unilateral solitary retinoblastoma, 85% have somatic mutation, but 15% have germline mutation at risk for a host of other problems. But really, it's more than that because it depends on the baby age at presentation. So we looked at 482 consecutive patients with one tumor in one eye to ascertain the percent with germline mutation based on age at presentation. And what we found in this comparative analysis based on age at presentation, 0 to 1 year, 1 to 2, 2 to 3, and more than 3 years. Those at greatest risk for germline mutation were those who come in with, again, solitary unilateral retinoblastoma, one tumor, one eye, but they're 0 to 3 months of age. They have a 61% chance that they're going to demonstrate germline mutation and get more tumors, bilateral tumors, pinealoblastoma, and second cancers. Then it drops for the 3 to 6 month, 6 to 9, and 9 to 12 months. It's about a 20% risk for germline mutation. Then it drops down to less than 20% or less than 10% for the older children. And we're publishing this in the Journal of Pediatric Ophthalmology and Strabismus in the next few months. And then a word about retinocytoma. What is the risk for transformation into retinoblastoma? Here's an example of retinoma and retinocytomas, benign variants of retinoblastoma in 6 different patients, none of which were treated and none of which showed growth into retinoblastoma. But there is a real risk. And we looked at 78, this is the largest series ever published, 78 tumors, retinocytoma, retinoma, and the rate of transformation into retinoblastoma over 20 years. So at 5 years, it was only 7%, at 10 years, 11%, and that persisted to 20 years. So I tell patients there's about a 10 to 11% risk that a retinocytoma retinoma might transform into a retinoblastoma and need treatment. Here's an example that we recently saw. A young child from Virginia came in to see us and has an obvious retinocytoma with surrounding RPE loss, but a viable retinoblastoma sitting right in the middle of this tumor. We shrunk that away beautifully with intraarterial chemotherapy. So these patients need to be followed just like retinoblastoma at least twice yearly for life. This will be published in the Journal of the American Academy of Pediatric Ophthalmology and Strabismus later this year. So last, just a comment. How do we feel about retinoblastoma? How does the patient feel about retinoblastoma? Well, a nice study out of India in the Indian Journal of Ophthalmology 2021 looked at this. They looked at 4 aspects of a child's health: their physical, emotional, social, and school domains. How are they doing if they have retinoblastoma? And they found that the quality of life of retinoblastoma survivors was significantly lower compared to sibling control in all 4 domains, but mostly in the physical domain and next the social domain. So kids aren't really doing that well with retinoblastoma, and we have to keep this in mind when we see them. Get psychologists involved. Okay, another question. How do we feel? How do the parents feel? Well, we did a nice study on depression, anxiety, and stress in parents of patients with retinoblastoma and published this in the American Journal of Ophthalmology. Our conclusions: the majority of parents display some degree of depression in 73% of cases, anxiety, 64% of cases, and stress, everyone. Severe depression was more often found in those children who have multifocal disease and previous history of depression and less education. So in summary, we've looked at Retinoblastoma 2021, the various types of chemotherapy that we use, whether it be intravenous, intraarterial, or intravitreous. We talked about unilateral, sporadic retinoblastoma. Watch out for those young babies, 0 to 3 months old. And retinocytoma carries that 11% risk for transformation into retinoblastoma. And lastly, we looked at the psychology of retinoblastoma. How are we doing? Well, we're doing well with tumor control, globe salvage, and life salvage for retinoblastoma. But we have a lot of work to do on the psychological status of the patient and the family. So Retinoblastoma 2021, saving lives and saving eyes. It takes a whole village to manage one child with retinoblastoma. Thank you.